So we are live.
So I think let's begin the proceedings of today's webinar. Okay, so let me share my screen. Give me a minute. There is some issue here. Okay. Can you see the screen?
Yeah.
Yes, sir.
All right.
Yes. All okay.
All right. Things are a bit of an issue here. Can't show my video. Can I do it here? Let me try. Choose start video. Okay. Fine. Even after doing 60, 70 webinars, you still many a times get into such kind of things. Anyway, so let's begin with the current settings. Today we would do a panel discussion on 5 cases of tetralogy of fellows, and with me we would have panelists Dr. Ladbans and Dr. Deepak Garg, Dr. Tanya as a radiologist, and Dr. Anupam Bhalla as a radiologist. I wonder why these names are missing. And Dr. Vidhi and Dr. Meetan are fetal medicine specialists. Dr. Meenakshi is our geneticist, and we are actually sharing with you our weekly meetings in the Prime Diagnostic Center. So let me start with the case, and if you see it here, this is a patient who is 19 weeks, 2 days gestation, and referred for a subaortic VSD. And I'm going to show you the video, and I request Dr. Deepak to tell me what are the findings here. Dr. Deepak, can you elaborate the findings, please?
Yes, sir. Sure. Thank you. In this video, this 4-chamber grayscale view, the cardiac axis appears slightly deviated to the left. The size of RV and RA appears enlarged in comparison to LV and LA. The morphology of the ventricles appear normal with moderator band seen in the right ventricle. The pulmonary veins appear to be draining into the left atria. So the veno-atrial and atrioventricular concordance is maintained.
So I think that's a wonderful beginning. I appreciate Dr. Deepak because he is kind of given you a segmental sequential approach, and there is no cardiomegaly. It is looking unremarkable except for a slight dilatation of an RA and RV, and that's what is very common in conotruncal abnormalities. Most of the time, the fourth chamber is normal or nearly normal. So now, Dr. Deepak, I'm showing you a color Doppler on the same place.
Yes, sir. In this color Doppler 4-chamber view, The inflows of the right ventricle and left ventricle appear to be normal.
Yeah.
Again, the RV and RA appears enlarged in comparison to the left side.
Perfect, sir. Perfect.
Yes, sir.
Another view now, we go to the apical
Yes, sir.
LVOT view.
In this apical 5-chamber LVOT view, sir, there is a subaortic VSD with override of aorta. The course of aorta appears abnormal and parallel to the ventricular septum. The aorta is receiving the blood supply from both ventricles. Aorta appears mildly dilated and shows a bit of turbulent flow inside it.
Great. Great.
Yes, sir.
Let's go to the next video. So this is the RVOT view.
In this RBOT view, the pulmonary artery appears smaller than aorta and it is seen rising from the RBOT only. The pulmonary valve appear to be normal. On color Doppler, there is forward flow, no regurgitation seen, and the aortic arc and ductus appear to be on the left side.
Yeah, I think that's perfect. That's really perfect because if you notice, guys, here Dr. Deepak has very nicely pinpointed and told you that the aorta is just slightly larger than the pulmonary artery, or in other ways, the pulmonary artery is slightly smaller than the aorta, and the issue is that aorta PA cannot be smaller than it can be either same size or it can be larger than aorta. If it is smaller than aorta, that is abnormal. That certainly is abnormal. So this is that means in totality what we have a VSD, we have an aortic override and the blood coming from both ventricles into the aorta, and we have PA slightly smaller. And Dr. Deepak rightly pointed out that the pulmonary valve is looking normal. Excellent. That's what it is. That's what happens in pulmonary stenosis. It is only the pulmonary artery which is small, which is making us help you the diagnosis of tetralogy of Fallot. As we know, the pulmonary artery isn't very remarkably narrowed. So we know this is a kind of a mild tetralogy of Fallot or a pink tetralogy of Fallot. So this might be actually thought that this could be just a VSD and no PS, but we got to be a little careful there. Dr. Vidhi is our fetal medicine specialist, and Dr. Vidhi, just I'm going to show you a couple of videos there. But before that, as Dr. Deepak told us that the components of tetralogy of Fallot, can you please enumerate the various components for making a diagnosis of tetralogy of Fallot in prenatal period?
So, as Dr. said, the prenatal diagnosis of tetralogy of Fallot actually has three features only, which is a subaortic VSD, as we saw in the previous case, a malalignment of the aorta, and pulmonary stenosis. So, the fourth feature of tetralogy of Fallot doesn't really present in the prenatal life.
Absolutely. The name tetralogy goes for four components. The fourth component is right ventricular hypertrophy that we generally do not see in the prenatal period. So you have three components, and if you get these three components, you are confident to make a diagnosis of tetralogy of Fallot. And the guys, let me show you all that. What I wanted to tell you is that this is a LVOT view where you see the aorta is overriding the VSD and the receiving blood from both sides. That's what we saw. And then you see the pulmonary artery, which is small. And this is how you make a diagnosis of tetralogy of Fallot. One interesting thing which wasn't present in our case, I'm going to show you a couple of cases with that, is that normally what you expect to get is that a PA would join aorta right at the apex here, and because the ductus is good enough and joins here and forms a V. Okay, but in the patients of tetralogy fellows, it does not form a V. It joins somewhere short of the apex, and we call it a T sign or a Y sign, whatever you wish to call. This could be either a T sign or you can call it a Y sign. That again indicates that the ductus and the pulmonary artery are smaller. They are not reaching the aorta at the place they should reach. To just give you an idea what I mean, that in case of you have overriding of an aorta, and then you see there is pulmonary artery and aorta, and you notice here the pulmonary artery actually joins, should have joined here. It joins under surface of the arch of aorta, making that T or Y sign, which is a very good clue many a times to make that this is a patient of tetralogy of Fallot. In fetal heart, we do look for all kind of possible clues, because these clues can save a day, because many a times you miss certain findings, and these clues would help you to sustain there and look for the abnormalities. Dr. Ladbans, who is a radiologist, the chief radiologist, and I want to ask her that, how would you tell the radiologist and fetal medicine specialist to differentiate tetralogy of Fallot from double outlet right ventricle?
Thank you for the question. I think we all face a lot of challenges when, it comes to whether it is 50% or not 50%. So one thing I would like to highlight before we take a further course is that you have, as Deepak pointed out, you have a parallel aorta. Normally, when you look at a normal LVOT, there is a wide angle between the aorta and the IVS. That wide angle is lost. So why it is lost? That should be the first clue for all of us to actually figure out why it is lost and try to look for the LVOT. So once you look at the LVOT, in TOF, what happens is there is an aortic override due to the discontinuity between the IVS and the medial wall of the aorta. So this is what is called as a shift of the aorta to the right, or it is also called as aortic dextroposition. Now, if it is 50% or less, then certainly we are looking for TOF, right? But if it is more than 50%, then certainly we would like to label it as double outlet right ventricle. Another very important aspect where we say it is TOF is that it is always a subaortic VST in TOF, whereas when you have DORV, it could be subaortic, it could be subpulmonic, it could be what you call doubly committed, right? So these are the basic differences. But in case of challenges, which I brought it out in the first point, that there could be challenges. So in case you are in doubt, whether you're looking at TOF, whether you're looking at DORV, or there is a confusion between the 50% less or 50% equal to or more than 50%, then please, you can use the terminology of TOF like DORV. Thank you.
Perfect. I think perfect explanation was many times what we are talking of a DORV of a TOF variety. When you have to differentiate DORV of a TOF variety from TOF, then these 2 points really help, whether the override is 50% or more, which means that each ventricle, to call it a double outlet ventricle, 1.5 vessel or more should be coming out of that ventricle. If there is a more than 50% override, obviously now more than 1.5 vessels would come out of the right ventricle. So that is, and I must tell you, where do you actually look for an override? The best view to look for override is an apical 5-chamber or apical LVOT view, not a lateral LVOT view. So mind it, you have to go to the apex to confirm it. Many a times in lateral LVOT view, you can get a difference of override. It might under or overestimate, but for confirmation, go to apical 5-chamber view. And second more important thing is that you have to have a conus? Why do you have a 50% override, and then there is a mitral aortic discontinuity, which Dr. Ladbans told you that this discontinuity is because of a conus present there. So now let me guys explain you what is the conus. If you are not comfortable, what do we call a conus? So I'm just sharing with you. Now first let's see the difference between the two. This is a DORV where you have an aorta, which I think is more than 60-70% override on the right ventricle. Only 20% is on this side. So we have no doubts here whether this is DORV or not. This is DORV for sure. But this is where is about 50%, 49, 51. I mean, we are not sure. Then we call it a tetralogy of fellows, or safely we can call it a TOF like a DORV, where you spell both the words, and then there is no challenge subsequently when neonatal echo is done. The diagnosis from TOF becomes DORV. It looks very different, but it isn't really different. And honestly, there is no difference of management of DORV and of a TOF variety and tetralogy of fellows, because it's a kind of a similar surgery. The outcome is same. It really doesn't make a great difference whether you call it DORV, but difference comes when you are talking about genetics. DORV would have a different genetics and TOF would have a different one. I hope Dr. Meenakshi would elaborate on that. Again, I'm going to spend a couple of slides on giving you an idea about the conus. Normally, embryologically, this is just to explain things. It might not be happening actually. Now, you have conus both in under the aorta and under the left ventricle and the pulmonary artery. So you have conus under the right aorta and conus under. So both the vessels arise from right ventricle to begin embryologically. What happens? The conus under the aorta gets absorbed. By absorption of the conus under the aorta, now it falls to the left and comes down and gets connected with the left ventricle. Okay, so when it gets connected with the left ventricle, that means normally aorta should not have any conus under it. Agreed? Then third situation is when the conus under the aorta is maintained, then it comes from the right ventricle, but the conus from the pulmonary artery gets lost or absorbed, and it falls down into the left and connected to the left ventricle, and there it becomes a TGA. So now what happens in TGA? There is no conus under the pulmonary valve. That means the pulmonary valve would have a continuity with the mitral valve because there is no conus there. Okay, and the aorta is separated from, in this situation, from a tricuspid valve because there is a conus there. So let's not complicate things further. Let's show you a case. What does a conus mean? Okay, so that's a case which I digged out from my archives for double outlet right ventricle. And if you guys notice here, this is the mitral valve, that is an LV, that's the mitral valve, this is the AML, and that's an aortic valve. Agreed? Now you have a distance from the aortic valve insertion to the anterior mitral leaflet insertion. This gap, you know what we call it? We call it a conus. So that means there is a aortomitral discontinuity because of a presence of conus under the aorta, and that's why this becomes a DORV and not the tetralogy of Fallot. So this presence of conus under the aorta, right, makes this fetus have a DORV, and that's how the normal looks like. The aorta, the anterior mitral leaflet, they snug each other with hardly any space in between, which is normal. If I show you diagrammatically, now you see, normally this is the tricuspid valve. You have a conus under the pulmonary artery, and then there is a pulmonary valve. Okay, so this conus separates the pulmonary artery from the tricuspid leaflet. It takes it away. There is a gap between the two. They are not continuous with each other. In a DORV, again, there is a subaortic conus which separates. This conus is a portion which is going to take aortic valve away from the mitral valve, which normally are snugged together. I hope now you understand the concept of the conus. Now, Dr. Vidhi told you that there are 4 components of tetralogy of Fallot, and we have a missing component of right ventricle hypertrophy. To tell you the truth, is actually monology. There's just a single component. Let me couple of slides explain you what is monology. In this notice, the septum shifts to the right and anterior, and by shifting of the septum, it narrows the pulmonary artery and produces an aortic override. So the crux of the thing in a tetralogy of Fallot is the conal septum, which moves toward the right side and anteriorly, making PA smaller and overriding of an aorta. So it is single component, then it creates the right ventricle hypertrophy. So where is the conus septum? Now imagine these two septa are basically kind of perpendicular to each other. This septum is in this heart, you can see this is vertically aligned and this is horizontally aligned septum. Both septa are horizontal. This is the conal septum. If it moves towards the right ventricle anteriorly toward and would obstruct the way of the pulmonary artery. This is right ventricle, this is right ventricle apex, cavity, right ventricle outflow tract, and this outflow tract gets narrowed when this septum moves towards the right ventricle, producing a subpulmonary obstruction or pulmonary stenosis. Another graphics I would show you. Now, this is the tricuspid valve, mitral valve. This is interventricular septum, and this is the conal septum, which is not aligned with the other part of the interventricular septum, which separates the bodies of the ventricle. Now, this is the conal septum. Now, if the conal septum moves anteriorly, what is going to do is going to create a VSD and going to shift the aorta, to override the VSD. And not only that, it's going to narrow down the pulmonary artery to produce pulmonary stenosis. So this is a single component which pushes on this side, produces a narrowing and an override. So which means more the conal shift, more is the override of the VSD, and smaller is the pulmonary artery. And that's what is the severity of the pulmonary artery stenosis. In pink tetralogy, going to a profound or a severe tetralogy, it depends upon how much conus has shifted to the right side. Dr. Anupam is a radiologist with us and working as a fetal medicine specialist. And Dr. Anupam, I'm going to show you a couple of 2D videos and as well as color Doppler. Can you explain by each video clip?
Yes, thank you. So here is the 4-chamber view. On the 4-chamber view is generally unremarkable, excepting for a slight prominence perhaps of the RA-RV. The squeeze of the heart is normal. The axis appears okay. The aorta is left-sided, and the tricuspid valve offset appears normal. Yeah, that's for the 4-chamber.
Yeah, I think it's looking great. It's looking normal. I agree. And the panelist guys, I just want to show you something here. You look at this structure, a kind of membrane thing here. This is fossa vallis bulging to the left. Agreed. What is this structure? This is Coumadin ridge. Okay. Yeah, this is Coumadin ridge. In case you see this Coumadin ridge, this rules out TAPVC. That is what article I published long back. Okay. So now let's see, Dr. Anupam.
Yes, this is the 5-chamber view in which we are seeing a loss of the aortoseptal angle. There is a VSD, a malaligned subaortic VSD with a prominent aortic root, which is overriding the VSD.
Absolutely good. So we move forward because this looks simple. We have already seen that. Okay, and then the next one.
Here we are on the three vessel view in which we are seeing the pulmonary artery appears narrower than the aorta, which appears a little larger, and the angle at which the pulmonary artery is joining the aorta is not the normal V configuration that we see. Rather, it joins it a little more proximally as you described as the T sign.
Yeah, good you picked up. Yes, you're right. There is a T sign. Absolutely correct. So let's move further. And Dr. Bhalla, now this is
Short
a
axis.
sagittal view of the heart. And could you really describe this?
Yes.
Not
So here,
usually taken by the radiologist and fetal medicine specialist, but we cardiologists do it regularly.
so this is the short axis view in which we are seeing the aorta in the center, and the right heart chambers are sort of wrapped around it. So we have the right atrium, the tricuspid valve, then the right ventricle, the outflow tract, and the pulmonary valve and pulmonary artery. So in the center, this circle should have been complete without any defect within it, in the margin of it. So the aorta one is appearing very large, and there is a defect that we are seeing, which is the VSD.
Correct. Absolutely correct. So the PA is actually smaller. And you guys, how do you differentiate? Is it aorta larger or PA smaller? Okay, so this is by the Z-scores. You do a Z-score. Otherwise, there could be two statements. I can say the aorta is large, or I can say pulmonary artery is small because, this is smaller than the aorta or this is larger than PA. So this is decided by Z-score. You take Z-scores. The aortic Z-scores are normal. The pulmonary artery Z-scores are in minus. That means the pulmonary artery is small. If pulmonary artery Z-scores are normal and aortic Z-scores are in the +2, +3 sign, that means this is the aorta, which is larger. Dr. Tanya, yes. Now, Dr. Tanya is a radiologist working with us, and let me ask her showing you this video. Dr. Tanya, can you describe this video, please?
Yes, sir. Thank you. So the first is the 2D or the grayscale video clip in which we can see there is discontinuity in the interventricular septum and the medial wall of the aorta, leading to the subaortic or malaligned VSD. In addition, we can see that there is overriding of aorta with mild shift towards the right side of the heart, leading to overriding of aorta. Also, we can see the aortic root is mildly dilated, and the pulmonary veins are seen draining into the left atrium in the first clip.
Yes, perfect, perfect. That's the perfect description of this video. And now the next one.
So coming to the second video clip, the color Doppler imaging of the above section. In this, we can see the color flow is from both the ventricles, the right and left ventricle, into the common outflow tract, that is the dilated aorta, giving the classical Y sign with mild aliasing in the dilated aortic root.
Okay.
Now coming on to the video clips beneath the first one. The first one is the grayscale 2D video clip. And this is the three-vessel trachea view. In this, we can see there is discrepancy in the size of the pulmonary artery, which appears smaller, and the aortic root appears enlarged clearly. And in the corresponding color Doppler image, we can see that there is a reversal of color flow in the ductus, and we can see that the pulmonary artery is smaller in size than the aortic root. Also, we can see that the pulmonary artery and ductus, they reach the aorta not at the apex, but just proximal to the apex, leading to the typical T sign or the Y sign as explained by sir and ma'am. And this aliasing is important because it will tell about the flow reversal in ductus, which signifies that there is increased severity of the pulmonary artery stenosis in this patient. Normally, if there is antegrade flow, that is a milder degree of pulmonary stenosis. If there is aliasing and reversal of color flow in ductus, it tells about the severity of the pulmonary stenosis or atresia.
Absolutely correct. So, guys, we were showing you all shades of, we showed you the pink fellows, we showed you a normal, slightly narrow pulmonary artery, the second one, which Dr. Anupam described. And now Dr. Tanya described a severer form where there is a, kind of a flow reversal, which indicates and cautions that this delivery should be done in a tertiary care unit in these patients. Dr. Vidhi, again, the fetal medicine specialist, could you uh, tell us that, okay, first is the diagnosis. You made a diagnosis based on a VSD, aortic override, and then the pulmonary stenosis. But we would like to know the severity of the pulmonary stenosis and what are the kind of parameters which you would consider are important for assessment of pulmonary stenosis or severity of tetralogy of Fallot.
So, yes, thank you. The primary, prognostication factor, standard variety of TOF is the degree of pulmonary stenosis. And to assess that, we assess the size of pulmonary artery. That can be done by taking Z scores. Subjectively also, well, there is a qualitative assessment of the size of the pulmonary artery. Then again, more the aortic override, of course, consequently, more the pulmonary stenosis. Other thing to qualitatively assess it is the flow across the pulmonary artery. Qualitatively, in terms of whether there is aliasing and whether the flow in the ductal arch is forward or reverse. When there is very severe pulmonary stenosis or pulmonary atresia, the flow in the ductal arch will actually get reversed. Degree of pulmonary stenosis can also be determined well by seeing the flow velocities across the pulmonary wall. More the flow velocities, more severe the pulmonary stenosis.
Great. Guys, I must tell you something that many a times we do see the pulmonary artery, like the previous case which Dr. Tanya described. You really saw that pulmonary artery wasn't too small. But the pulmonary artery doesn't have to be really very small to have a reversed flow. Many a time the pulmonary artery size appears kind of okay. So you must put a color Doppler in a three vessel trachea view and look for a flow direction. That's very, very important. Size could be, giving you a miss signals. Okay. So when you do an aorta, then the next one is you go to a pulmonary artery, and then you must look for the branching. I think develop a habit of looking at the branches of the pulmonary artery. They are very important. There are certain conditions where the pulmonary artery may arise from the aorta. It's not coming out of the main pulmonary artery, and there's other pulmonary slings which you would miss unless you see the bifurcation. So must see a bifurcation of aorta. And we know that the right pulmonary artery is said to be an important marker for severity. So I just enumerate various things, what the measurements we take. We take the measurement of the pulmonary artery, we take the measurement of the annulus of the aorta, we take main pulmonary artery, then we take the right pulmonary artery, we take the descending aorta diameter at the level of the diaphragm, and there are many Z scores available. Z score of a right pulmonary artery or a main pulmonary artery less than 3, less than -3 is said to be a very bad prognostic sign, a caution, right? But otherwise, you can use these ratios, which are very helpful because these scores are really honestly very tough to, kind of standardized when you are doing it. So there are two ratios, which I would say a rule of two-thirds, that the pulmonary annulus and aortic annulus, the pulmonary annulus is less than 66%, and the ratio is less than 66, and the right pulmonary artery is two-thirds of the size of descending aorta. These two markers give you a reasonable clue to the severity, and people have found the outcome of surgery and outcome in the neonatal period is very appropriately guided by these parameters. Talking of surgery, I'm not going to teach you surgery, neither do I know about it, but I'm going to tell you what surgery you do it. You at least have a concept how the surgery is done so that you can counsel the patient, and you should know based on what surgery is done that why do we say the pulmonary artery size is important after all. Okay, so we normally do a corrective surgery. In the corrective surgery, it's ideally done in 3 to 6 months of and ideal anatomy. Ideal anatomy of what? Ideal anatomy of pulmonary artery and pulmonary annulus. Okay, and then there is a stage surgery when the pulmonary arteries are really small. Then we do something to correct pulmonary arteries. We connect artery into the pulmonary artery and let them grow. The pulmonary arteries, as they grow, after the first palliative procedure, the corrective surgery is done, and I'm going to tell you. This is how we began with. We actually thought that neither right ventricle is very important for life, nor is the pulmonary valve or tricuspid valve. That was our concept in the past, and we thought we can. How do we repair the tetralogy of Fallot? Let's cut the ventricle. We did cut the ventricle. We saw a nice clean VSD. We put a patch on the VSD. So that's what we did. And then we cut the pulmonary artery and cut the pulmonary valve. Hell with the pulmonary valve. We cut the pulmonary valve. That's not important. We do that. So we've done it. And then we cut this and put a patch on the VSD. Simple looking surgery, very nice, surgeon happy, patient happy, goes home, comes back after about 10 years, 15 years, between 10 to 20 years, they would come back with a severe pulmonary regurgitation, markedly dilated pulmonary artery. From a tetralogy of Fallot, you have converted this patient into an absent pulmonary valve kind of situation, and that puts a hemodynamic load on the right ventricle. And many of these patients where the right ventricle fails to a degree, about a third of them would require another surgery, that is the pulmonary valve replacement, which is not a good thing to have. So then we learned from our past and we said, okay, we are going to improve. And how can we improve? Let's forget about respect right ventricle. If we cut the right ventricle, the muscle is gone and it cannot tolerate pulmonary regurgitation. So let's save the right ventricle. Not only that, it does not produce arrhythmia. So let's save the right ventricle. We make a small cut here in infundibulum. We clean the infundibulum stenosis. Then we cut the right atrium. That's how normally we approach the ventricle septal defects. We don't approach ventricle septal defects from the right ventricle. We don't cut it. We go to the atrium. To go to the right atrium through the tricuspid orifice, we see the VSD and we operate. And then we cut the pulmonary artery on the top. We put a patch, enlarge the pulmonary artery, and we enlarge slightly the annulus, trying to save the annulus. And so this is, now remember, if the pulmonary artery is of reasonable size, only then you'll be able to do this corrective surgery. Okay? Otherwise, if the pulmonary artery is small, we need the pulmonary artery to grow. And how do we do that? We put a BT shunt from a subclavian artery into the pulmonary artery. Though there is a systemic shunt we create into the pulmonary artery, more blood goes into the pulmonary artery, which otherwise should have come from the right ventricle, doesn't come from the right ventricle. Now it comes from the BT shunt. The arteries grow, and then when they grow to a reasonable size, we do a corrective surgery sparing the pulmonary valve. So you got it. Now this was the reason why we were after pulmonary artery, the size of the pulmonary artery compared with aorta, pulmonary artery compared with descending aorta, blah, blah, blah. This was all the concept. Dr. Meetan, are you there? We have the next case now, case number 4. And can you describe the findings on the 2D?
Yes, sure, sir. So first, grayscale axial image. Number one, what I see is that the heart is a little globular. It's not as longitudinal as I want it to be. So I would want to do a sphericity index here just to make sure that there is no LVRV dysfunction. Other than that, going from the ribs anterior, I see the aorta well placed on the left side, which is normal. The space between the aorta and the left atrium is normal. I see normal pulmonary veins opening into the left atrium. Right atrium is okay. The flap of the foramen ovale is fine. Both the valves are doing well. The crux is also present, and both left ventricle, right ventricle, absolutely fine with the moderator band in the right ventricle on the right side.
Perfect, Dr. Meetan. I think you really nailed it. The thing which I think could have gone unnoticed is the shape of the ventricle. And let me tell you, when there is a ventricular dysfunction, the very first thing what happens, Devor described it, and I talked to Devor, and he said that this probably is the first thing to happen in all your patients of a placental insufficiency or ventricular dysfunction because of any reason. Heart becomes globular. It remodels itself to reduce the wall tension. Okay, so sphericity index is a good, and it's a very simple thing. You take a measurement in the mid diastole, wherever is the longest, and you take a longer diameter. Then if you know that if it is larger than this diameter, it looks circular, or let us say both diameters are the same, vertical, and that is a spherical heart. Okay, so now let's move to the second clip, Meetan.
All right. The second clip, obviously, we see the loss of aortoseptic continuity with the aorta sort of coming out right in the center, the receiving supply from both the LV as well as the RV, classical Y sign, which tells me that I'm looking at TOF type picture.
Yeah, good. I think here, if you could notice, the mitral and aortic continuity is still maintained. So we would, kind of say that there is no subaortic conus, and I think, and that's that. What, but incidentally, I had recorded multiple clips. We did not see any pulmonary artery, any other outflow vessel from the outflow tract. So. Now issue is that where is the pulmonary artery? The survival is not possible because pulmonary artery, it has to be somewhere. So Meetan, Dr. Meetan, just let me know, once you have this kind of situation, where all you would, how would your search start, and what do you tell the fetal medicine specialist? How should they approach a patient where you have a single outflow tract and the pulmonary artery is not coming out of the ventricular mass?
All right. So if I have no no pulmonary artery which is coming out from the obvious RV or the LV, I would see the single outflow tract first. I would try to locate a conotruncal abnormality. I would like to see whether there is any pulmonary artery which is coming out from a single trunk. If not there, I would go to my 3-vessel view, and I would like to see the ductus there. I will put on color. If I see ductal reversal over there, if I see with, if I'm looking at an axial section and an apical heart, if along with the blue line, I see a red dot on the site, I know I'm looking at ductus reversal, and I know the pulmonary artery is very, very small or is very, very stenotic. And if I still don't find it there, I would like to go to the descending aorta down further and search for probably MAPCAs or any collaterals which are supplying.
Yeah. Central map. Because I think this is the way it is. As you scan from LVOT, you go up and look at the aorta. You thinking which is aorta may not be aorta. It's a common arterial trunk, and pulmonary arteries you can see coming from the posterior aspect or from the sides. So if you have a single pulmonary artery coming out of the ascending trunk, then you call it a truncus or common arterial trunk. But then the second is you can see it from the arch of the aorta or isthmus. And if you don't see the pulmonary artery, you go below the isthmus and try to find the central collaterals. Dr. Meetan, in this patient, this is what we saw.
Yes, so central collaterals are glaringly visible arising from the descending aorta, going up and trying to supply the lungs along with the, become the pulmonary arteries basically.
Yeah, absolutely. So same on the lower panel. This is ascending aorta, this is descending aorta, and like you rightly said that there are so collateral. So whenever you have any issue, you just do that. In case still you don't find pulmonary artery, we try to see any branch pulmonary artery and try to go proximal and figure out where the pulmonary artery is. That does happen in patients where you have a poor acoustic window. So these are the central collaterals which go into the lung and supply the lung. This makes the life of a surgeon very difficult because they have to collect all these arteries and make it to join into a conduit coming from the right ventricle. We call it centralization of the pulmonary arteries. Dr. Ladbans, I would show you one video, and this is Dr. Ladban. This is a very interesting case. So I want you to pay attention and tell us what do you see here. A lot of findings, right?
Yeah. Thank you. So what we see in this transverse section of the fetal abdomen on a color Doppler, I do see the stomach, which is on the left side. I do see the aorta, which appears to be slightly central anyway. But more than that, when I see the intra-abdominal segment of the umbilical vein, what I'm trying to see is that normally we should see the convexity to the left. So here I do see the convexity to the right, and I do suspect that maybe I'm looking at a persistent right umbilical vein. So as far as the transverse section goes, I do not see anything more than that. So I would like to have more views for the fetal heart.
Yeah, sure. No, we didn't have any more view for the, umbilical vein, but we went to the apex and I'm just showing you apical fourth chamber view.
Okay, on a 2D grayscale image of the transverse section of the thorax shows me that classically I'm looking at the deviation of the heart towards the left side with the axis to the left. I do also see that there is a relative dilatation of RV as well as RA in comparison to LV and LA. And the morphology of all the chambers appears normal. So are the connections as well, the venoatrial as well as the atrioventricular.
Here, I think you guys, we were sitting together and you pointed out that there was
I
a
do
little
also see
increase
some
in
kind
the
of trabeculation, which is very well brought out in this particular view.
right
I think
ventricle.
it's,
Yes.
yes.
Okay.
So
Yeah.
that's the trabeculated RV, which is, it's seen much better and much clearer in this particular view, telling us that we are looking at a normal, morphologically normal RV.
So many a times in where the apical, the view is little angled or it's not proper sectioned, then you do see pulmonary artery, but then you many a times see a gap between aorta and LA wall. So, that is just a sign. So if you see this, just don't jump to the diagnosis of TAPVC. Look at the pulmonary arteries.
Okay.
So that's a color Doppler of fourth chamber view.
Yeah, I just like to point out, I think maybe our ultrasound beam was perpendicular to the previous section on 2D, so maybe that's the reason we are seeing the trabeculations much more clearer.
Yeah.
So as far as the color Doppler of the same goes, it's certainly the inflows are absolutely normal. The normal inflows seen at the tricuspid and the mitral valve. And apart from that, there is a relative predominantly enlargement of seen involving the RA and the RV.
Yes, I think I told you there are a number of findings here. Just keep looking, you'll see
I
something
know,
here.
I do because it
Yeah,
it
that was to
stopped
your
in
notice.
between.
Yeah.
Yeah.
So I
So
this
I
is what.
think, yeah. So what we do see is apart from what we are seeing, as I told you before, and in addition to the aorta, which appears to be slightly on the right side in this particular view, and apart from looking at aorta, I do see a large vessel, which is seen here and is showing the same flow as you see in systole. It's persistently seen in systole, That means it tells me that I'm looking at some arterial vessel. So it's a vessel which is, and basically it's a artery. So that, and if I compare it with the adjacent aorta, is appears to be significantly dilated. Normally, we should not be seeing such kind of vessel in behind the heart. So that gives me, I would like to see it more further. I'd like to try to go into 3VT so that I try to see that whether this vessel is trying to arise from RV or what kind of vessel am I looking at. So that makes me more inquisitive. So as you see in this particular view, I do see a malaligned VSD. I do see that there is an overriding of the aorta, 50%. And apart from that, I do see there is a large vessel here, which on color Doppler is showing you continuity with the RV. If you just stop at the last point of this particular video, you will see that it takes origin from the RV, and this is probably the large pulmonary artery. Yes, the large pulmonary artery, which you see and is showing a lot of turbulent flow. Right? Similar flow, if you see carefully in the RV, if you just play the video, please, if you see the RV is also showing you a similar kind of turbulent flow, right? The similar to and fro flow, which is appreciated in the RV, which is dilated, and also this dilated structure, that is the dilated pulmonary artery, which is seen and is showing you a to and fro flow, telling us that I'm looking at a very turbulent flow within the dilated pulmonary artery. And I'm certainly, if I'm looking at this particular thing, my first thing would arise that normally in TOF, we do have a small pulmonary artery. And if it is dilated, that means I'm looking at an absent or an aberrant or a dysplastic pulmonary valve. So my search would certainly increase further with this.
I think that's an excellent point. I also did not notice it, but while I'm running this video, I want you to show guys. Now this is inflow, agreed. This is in diastole. You see this inflow, both in LV and RV. Keep watching it. And then you see then there is hardly anything in LV. You have some flow here, right? So look at this flow, the red color. That's what Ladbans was trying to explain, that you see some odd kind of color in the right ventricle, which in fact, she was absolutely right, was because of an absent pulmonary valve. And here the clip, Dr. Ladbans, which you were trying to hint at.
That means the severe pulmonary regurgitation, which you see a to and fro flow across the pulmonary valve. The similar flow is appreciated in the dilated RV. It is striking back and coming right into the pulmonary artery, which is showing you an aneurysmal dilatation, right? If you compare it with the aorta, it is, I think, more than 4 to 5 times dilated. And this is this is seen with an absent or a rudimentary or a dysplastic pulmonary valve when you see it with a TOF. So if you have
Great.
more views, I would like to,
Yeah, sure.
comment upon that.
I do have more views because this is very interesting patient. So I do have.
So if you actually see this particular clip, now apart from that findings, which I've already explained to you, I do see that the aorta is, I need to see my complete convergence of the aorta with the pulmonary artery. That's
Okay,
the
that's the
aorta
next
which I
view.
see, and I am unable to see the convergence. Rather, it is abruptly cut off from here, and it is completely dilated, the pulmonary artery. And if I compare it, even in this above clip as well, if I compare it with the size of the pulmonary artery, the aorta is normal, rather, I should say aorta is normal, and it's the pulmonary artery which is dilated in the above clip, as well as the moment you start with the
Fine. Great. I think what you do is that you describe this, the next video. And in the meantime, let me find out my charger because my battery is running a little low.
That's
And
fine.
please describe this
So what
video
is
and the
happening?
next
Normally, we should
image.
see the convergence of the aorta as well as the pulmonary artery to the left. Now, since I do not see the convergence, the aorta is to the right side. There is no convergence, one, and the aorta is seen to the right side, right, of the trachea. That means you have a right-sided aortic arch and you have a left-sided pulmonary or the ductal arch, but the ductal arch here is not seen. You do not see the convergence. Okay. So, and similar thing which you observe is on the severe PR, which is appreciated in this particular spectral tracing, which has been taken across the pulmonary valve, where you see the retrograde and the antegrade flow, which is appreciated through the pulmonary artery. So I do have a right-sided aortic arch, right? And I have a normal left-sided pulmonary artery. I do not see the ductal arch. I do see the SVC. Aorta is normal in size. I see the trachea in the center, and I don't see the ductal arch. And at many times, once you have a case of TOF with right-sided aortic arch, remember, when you do not see ductus arteriosus, it is either could be found as absent, or you could not see it. One, it could be absent, or it could be hidden under the right-sided aortic arch, or it could arise from the right pulmonary artery. So these three things you must keep in mind. There are many a times, it's written in literature, often in TOF with right-sided aortic arch, you may not see the ductus, which could be absent or hidden under the right aortic arch, or arising from the right pulmonary artery.
You got a very good point. That's absolutely right. And the flow here, we'll just go a little fast from it because just 5 minutes left. Pulmonary stenosis and regurgitation flow, and that's the final diagnosis in this patient. And guys, I should tell you, these patients don't do well because the outcome is little different than the regular tetralogy of Fallot, because the dilated pulmonary arteries end up compressing the bronchial tree and can produce respiratory issues. And we are just close to the end of the webinar, and Dr. Meenakshi is going to give us the final word on, how would you approach a patient when I make a diagnosis of Tetralogy of Fallot, and we refer it to you, and then you make an assessment. Dr. Meenakshi, are you there?
Yes, sir. Yes, sir. Thank you, sir. So whenever I see a patient of TOF, the first question that I want to be answered is that, is it a syndromic or a non-syndromic? So the TOF is an isolated finding, or there are many other extra cardiac findings that are there. And if there is some growth restriction, because if there is growth restriction, extra cardiac findings, then I am looking at a syndromic TOF. For syndromic TOF, we know that genetic testing is must. It might not be very good prognosis because it is associated with chromosomal anomalies like Down syndrome and most prominently 22q deletion syndrome. But if it is, so everybody knows that. But talking of the isolated TOF, because isolated TOF are also very, very common. And those are the patients which we have discussed have such good surgical outcomes also. So for isolated TOF, genetic testing should be done? We should actually test, because sometimes the findings in DORV or 22q are very subtle and might not be present in all the patients. So we should offer this testing to rule out DORV syndrome. And also I have the other genes which can be implicated are frequently seen are the JAG1, Notch1, which are included in Alagille syndrome. Alagille syndrome is associated frequently with TOF and might not have a very good outcome. The second genes which are very, I've got a patient with ABL1 mutation. And ABL1 mutation, the patient has skeletal phenotype, the cognition is normal, there is TOF, and failure to thrive during the infancy. So those patients will also do good with counseling, and they will get a green flag from our side. The other mutations are because the TBX1 gene is mutated, is deleted in DORV. So TBX1 single point mutations can also lead to TOF etiology. But still, most of the TOF patients are due to a large number of genes acting together, modifier genes, environmental influence coming together. And so it's a multifactorial etiology where at present we might have all the genetic testing as normal.
Great, Dr. Meenakshi. More we learn about genetics, more we learn that less and less we know about it. And thanks for elaborating it. And I think we would wind up with Dr. Meetan. She is a gynecologist and fetal medicine specialist, and she's going to guide us that, okay, if I have a patient with tetralogy of Fallot, what should be the plan? Where should we do the delivery, and how should we go about it?
Right. So two counselings, I think they're very necessary. One is that we have to counsel ourselves as obstetricians, and we have to have good pediatrician support. We have to have a pediatric cardiologist in a loop with us, antenatally as well as postnatally. The delivery decision, whether vaginal, cesarean, depends on, again, the severity of TOF, depends on whether there are any antenatal complications associated with the TOF or any obstetric obvious indications. Secondly, the second counseling, which is the most important counseling, is for the parents, and they have to be told that the baby would not be there immediately with them, like in other normal scenarios, and the baby might be taken away to an ICU, to a pediatric ICU for an echo. They might have to go in, come back, and you know do all of that. Go through all of that hassle rather than a simple normal delivery.
So great. I think there were pointers which actually can guide us that these patients should be done in a tertiary care. But I think ideally, most of the patients should be requested to get delivery done at place where you have the unit of pediatric cardiology nearby. So thank you very much, guys, for being a very patient with me and digging out new things which I made you to pick up, and I think it was very fruitful. All of us, I hope, would have made a lot of learning for fellows, those who've joined us on YouTube, those who are looking us live to know about Tetralogy of Fellows. Please leave some comments in the YouTube channel. You can post the questions. Maybe I'll be able to take the questions live, or maybe I'll take the questions on the YouTube channel itself. Thank you, and bye from then. Thanks all the panelists for your support.
Thank you so much.
Thank you so much. Thanks.
Thank you, sir.
Thank you, sir. Thank you. Bye.
So we are going offline now.
Yes, sir, we are fine.
Chalo, I think that was good. Tell me, guys, how did we do?